Hi, everybody. I'm going to go over with you the exam 3 study guide over postpartum today. So, this should help you study for your exam. Again, it's your ATI book. Please study that, read it, highlight it. Whatever I emphasize, please go back over that material, do your Jeopardy, and of course, listen to my recorded lectures as well. But this will kind of narrow it down just a little bit for you to see what's on my exam. So let's begin. I'm going to share my screen with you. Okay. All right. So study guide 3. As you can see here, it's everything postpartum. I know we've discussed, I think, most of this, or if not all of it, in class from the book. So you can see here what's on there um, as far as routine assessments, and then, of course, signs of complications and interventions that we do for postpartum mothers, medications, and any postpartum disorders and education. So I want to, in addition, I pull it up. Okay, here's my ATI book. So we start with chapter 17, physiological adaptations of postpartum. Okay, it talks about what happens to the body afterwards, um, as far as physical changes and lactating changes, hormonal changes. Main thing in this chapter is our bubble assessment here that we went over in quite some detail in class. Um, and I'll talk about that as we go along. So know what those all stand for. Do also know your vaccines. One of them is the RhoGAM. Within 72 hours after delivery, we need to administer that to any Rh negative mother that gave birth to an Rh positive child. And remember, this prevents sensitization. It prevents the antibodies from building up. Once the mom is sensitized, let's say they forgot to give her RhoGAM and she's sensitized, RhoGAM won't do anything because the antibodies are already there. So RhoGAM prevents the antibodies from building, okay? And helps with future pregnancies. Okay, so fundus. Remember we talked about fundal height, tone, and position. We need to know the height. Remember at the umbilicus is UU. Typically on delivery day, that's usually where it is, right at UU. It should be midline and firm. Each postpartum day, it should go down by 1 finger breadth or 1 centimeter. So U1, U2, U3. And if it rises above, which is called subinvolution, which is abnormal, it would be 1U, 2U, 3U. So if it's up high, the number's first. So 1U. If it's below, it's U1. All right. So typically 1 finger breadth per day is what it goes down. Consistency, we want it to be nice and firm as opposed to boggy or uterine atony, which is the #1 cause of postpartum hemorrhage. And then, of course, we want it to be midline. And we know that things like a full bladder can push that up and over, displace the uterus. So it should be nice and midline for us. Certain things we can do to help with that involution is oxytocin. Of course, any oxytonic drugs that can um, give the uterus more tone, helps it contract and keep it firm for us. So we'll talk about some of those medications when we get to postpartum hemorrhage. Mom should also empty her bladder every 2 to 3 hours to prevent that bladder from getting in the way of the uterus contracting. If mom is breastfeeding, that does release oxytocin naturally. So again, that helps with contracting the uterus. So a lot of moms, when they breastfeed, will complain of cramping. Lochia, know your 3 stages: rubra, serosa, and alba. Rubra is 1 to 3 days, bloody. Consistency can contain small clots. Serosa is pinkish, lasts 4 to 10 days, and then alba, 11th day to 4 to 8 weeks, which is a yellowish or whitish creamy color. So teach mom normal lochia so that we know when it's abnormal what would be a concern with hemorrhaging. So we want to know our amount on the pads. Remember, scant to heavy. So scant, small, moderate, large, and excessive. So look at her pads, and if need be, if she is hemorrhaging, we may need to weigh those. Remember, like we did in our simulation. When you weigh them, you subtract the weight of the dry pad to get your estimated quantitative blood loss if she's bleeding a lot, okay? Um, Manifestations of abnormal lochia, again, we're looking at amount, consistency, and then also we're looking at odor. Should have a fleshy odor, but not a foul odor. Foul odor could mean infection. Rule of thumb is if she's saturated a pad an hour, that's too heavy. So we want to intervene with that, which we'll get to. Another thing we're going to assess is any lacerations or episiotomy. We're looking for signs of infection. So redness, drainage, swelling, and that could be a uterine incision or an episiotomy as well. And then remember, hematomas can occur, and they will feel a lot of pressure in that perineal area just from that collection of blood underneath the skin. So remember to assess an episiotomy or for hematomas or hemorrhoids, put her on her side and assess it from that sideline position. That is the best way. Know your perineal care. Things we talked about in class, the little spray bottle that she should use with, warm water every time she uses the bathroom, squeeze front to back, remove her pads front to back. She should change her pads every time she uses the bathroom. She can use spray, to help with the pain. Ice, of course, can help with swelling. Witch hazel pads also can help with that pain, also with hemorrhoids as well. She should pat or blot, do not wipe because we don't want to dislodge any stitches. Breasts, we talked about that in class. So breastfeeding, we need to assess for skin breakdown as well as signs of engorgement, and then also signs of infection, which we'll talk about again when we get to our infection chapter. So look for any redness and tenderness of the breast. We know that colostrum is the early milk, and the mature milk comes in around 3 days. So around day three, she'll feel that engorgement. Her breasts in the meantime will be filling. They'll go from soft to filling. So we're going to be assessing that. And again, if she has any skin breakdown, we can use lanolin cream. We can use nipple shields. She could even pump if the pain is too severe. To nurse, we can pump through that time while her breasts heal. A good supportive bra. And then again, she can hand express milk and use heat to help let down that milk. Sometimes when moms are engorged, that milk can be really difficult to let down. So remind her to use that. If she, early breastfeeding and on demand, remember 8 or more in 24 is what we want. So the baby should eat at least 8 times in 24 hours. And we talked about the different positions in class. So whichever one's most comfortable for the mom is what she should use. The baby should latch properly. Remember, the baby should get as much of the areola in their mouth as possible, and their lips should be flanged out as opposed to sucked in, because if they're sucked in, that could break down their skin a lot quicker. So we're going to be assessing feedings. So it's not only important for the baby to intake and get milk, but it's also important for mom's breasts as well. If she's not breastfeeding, ice packs are great. No heat, so no hot showers facing the water. She should not hand express because whatever she hand express, the body is going to remake. And again, a good supportive bra. Let's see. Normal blood loss is still an ETI 500 mLs for a vaginal delivery and 1,000 mLs for a cesarean birth. And that's total, not just at the birth, but total throughout the postpartum process. Okay. So if she had a large blood loss in labor, like after delivery, then we're going to really have to watch it. We're going to watch her blood levels. She will be diuresing a lot because we know that moms have an increased cardiovascular volume anyway during pregnancy, so she will be getting rid of all that. So again, the importance of emptying her bladder every 2 hours is super important. To prevent DVTs here, early ambulation, STD hose, anti-embolism stockings. To help prevent that, assess for those signs of DVT, looking for unilateral swelling, any pain in the calf or behind the knee, and then redness as well. Constipation can be an issue after delivery from anesthetics, from trauma, from abdominal surgery, opioids. So we're going to give stool softeners. We're going to encourage lots of fluids, early ambulation. And remember, we can give enemas or suppositories, but if mom has a 3rd or 4th degree episiotomy, and those, remember, are when they go to the rectum or through the rectal mucosa, through the sphincter, they are contraindicated. No enemas and no suppositories, but we can still do fluids or early ambulation and stool softeners. We're going to be assessing her bowel sounds, assessing for any signs of nausea, teaching her to eat a lot of fiber. And spontaneous bowel movements might not occur for 2 to 3 days after delivery, and that is okay. That is normal, but we got to make sure that her bowels are active. We have active bowel sounds. She's passing gas, and things that could even further inhibit it would be operative vaginal birth, so that's forceps and vacuum as well. Okay. With the urinary system, again, we talked about in class two things. UTIs are going to be a risk factor just from catheter use. Hold on one second.